All right, guys. So let's talk about some neurological problems. So tonight we're going to talk about increased ICP. And this is definitely going to be one of the most serious problems that you can have neurologically. And it's something that can be a result of a lot of different conditions and lead to a lot of problems. So it's definitely a concept that you want to get down. So first, let's start out when we're saying ICP, what are we talking about? We're talking about when we're saying ICP, we're talking about intracranial pressure. And what intracranial pressure, ICP, is, it's the amount of pressure within your skull. So kind of think of it like the blood pressure of your brain. So it's the pressure in the brain and in the cerebral spinal fluid. And the big deal with too much pressure, just like anything, like with high blood pressure, the blood vessels can rupture, so much. Same if there's too much pressure in your brain, what happens is you have to think about where your brain is. It's in the skull, in this hard, encapsulated. Pretty much think of it's like a fixed area. Like these hard bones of my head. They say we're hard headed. That we can't expand past this. So think of this almost like a device keeping your brain in place. So if my brain is getting more pressure or expanding, getting swollen, there's more pressure building up inside. I only have so much space to stretch. And what happens is once I can only stretch so far out, what happens is then my brain starts going down because it has nowhere else to go. It can't go up or out. So it starts pushing down. And what's on the back here of my brain? Well, if you don't know, it's your brain stem. And your brain stem is in charge of all of your big important stuff: breathing, blood pressure, heart rate, rhythm, like all that stuff. All the stuff that's keeping you ticking is in that brain stem. So in other words, what happens if I build too much pressure in here, I can't expand out because there's only so much room here. So I start pushing down on that brain stem. And eventually that pressure on that brain stem leads to what's called herniation and brain death, because that's like the death of all of my vital functions because there's just no more room. It's literally just kind of getting suffocated, squished in. And so pretty much my role as the nurse is going to be there to not only monitor patients that are at risk for increased intracranial pressure or that have increased intracranial pressure, but also try to prevent it from getting worse. And so when we're talking about intracranial pressure, we're not talking about it like, you have high blood pressure and low blood pressure. Really, we're most worried about intracranial pressure when it's too much. Of course, yes, you do need enough, but when we're talking in this section, we're talking about increased ICP, or one that's too high, because that's really our focus in this section. What happens when pressure gets too high? So I said there was a lot of different causes, and this kind of comes down to like all perfusion in the body. It's all about supply and demand. And so, effectively, anything that's going to decrease my supply of oxygen or ability to get oxygen to my brain, or anything that's going to increase the demand, can end up with, too much swelling, too much overworking of the brain, too much pressure. So, things like trauma, things that cause swelling, infections, they cause a lot of work, edema, injury to my brain, tumors take up space, stroke decreases perfusion, aneurysm, seizures, high blood pressure, lack of oxygen. All of these things are going to increase the pressure in the brain. And the brain is really sensitive. We're going to talk about, interventions for increased ICP, and you're going to see a lot of them have to do with, your managing your blood pressure, managing your oxygenation in your body and your CO2 balance. So there's a lot of factors that can play here. But effectively, anything that affects that could cause the brain to swell, anything that affects the oxygenation of the brain, anything that causes trauma or damage to the brain could lead to increased ICP. So we have to kind of understand just at a basic level, and I know a lot of times for students, you guys go a little too in depth with these things. We have to understand at a basic level, how do we regulate pressure in the brain? So, similar to the fact that there's a map, like a mean arterial pressure in your blood pressure in your body, there's also what's called CPP, which is cerebral perfusion pressure. And this tells us how well the brain is getting blood flow. And as the actual equation, this is an equation I would want to know if I were you. It's the cerebral perfusion pressure. How much pressure I have in my brain is equal to my mean arterial pressure minus my ICP. So in other words, the amount of flow I have up here is equal to the pressure in my body, the blood pressure in my body, minus how much increased pressure I have up here. So in other words, like, these are the two factors. One, I have to consider how much blood flow does my entire body have? And then two, how much pressure or resistance do I have within my brain or CSF? So almost think of this like if you want to go back to your favorite days in cardiac, think of systemic vascular resistance, like all that resistance that the heart had to overcome to pump blood out. This is the same thing as that's kind of like what ICP is. MAP is how much you have like flow you have to go to the brain, but the ICP is the resistance or what the body has to overcome in order to get that perfusion to the brain. So this is important to know this equation not only because it's a great test question, but on top of that, it really helps you to know if what affects my blood flow to my brain is going to be my blood pressure or how much resistance I have up here. That's the two things I can do as a nurse to help this patient. So a lot of our interventions are going to be focused on what can I do to the patient's map to make sure they're getting enough blood flow. So in other words, I want my map to be up, and we'll talk about what we want those numbers to be. And then for ICP or resistance, I can't have that number be too high. So I want my ICP lower. I do not want too much pressure because too much pressure, too much resistance means I'm not going to get flow. I'm not going to get perfusion or oxygenation. So in other words, I want my MAP high, my ICP low in order to have a good CPP. So let's look more at these numbers. So normal ICP, and again, I always tell students like this is what your book's saying. In the real world, we kind of say like 10 to 20, but your book and per your testings, this is the numbers you're going to want to know. A normal ICP, remember that's that resistance. We want it to be 5 to 15. So we don't, once it gets above that 15, we're starting to worry about the patient getting too much pressure, and then pressure on that brain stem where it can lead to them, completely losing those functions and becoming brain dead with too much pressure. The normal general perfusion we want in the brain is 60 to 100. So that's that cerebral perfusion. So kind of think of that like the map in the head. And then a normal map, we talked about when we were in cardiac about it being greater than 65. But in order to get good cerebral perfusion, we actually like it at 70. And sometimes you're going to, listen to your professors. If they say it's any number higher than this, then go with what they're saying. Because a lot of times for patients that have brain issues, we're not messing around. We can't mess around with, are you getting perfusion to your brain or are you not? And so a lot of times for us, in order to get a good CPP or overall, good pressure here, I need to have a higher map than a normal patient because it's all about getting that perfusion to the brain. So what does a client with increased intracranial pressure look like? So, one of the best measures in neurological status in general of how a patient's doing, how much blood flow or perfusion they're getting to their brain is going to be their level of consciousness. And it's really important to know the difference between level of consciousness and orientation because a lot of students get these mixed up. And, when it comes to level of consciousness, this is saying how awake are you? Whereas orientation is, do you know what situation you're in? Like, do you know who you are, where you are, why you're here, and around, when it is, like, do you know what month it is? So it's like more about knowing about situation where level of consciousness is how awake are you? If I go into your room, how much stimulation do you need to respond to me? And are you responding to me? Are you waking up? So, pretty much the brain shuts down really easily when it's not getting enough blood flow. So that altered level of consciousness is really our first early sign that something's not right up here. If I'm not waking up, if I'm not responding the same way I was, that's really showing there's a sign of a problem. There's also going to be changes to vital signs. And when it gets really severe, now when I'm looking at this Cushing's triad below here, keep in mind, like this is a late stage. This isn't something that happens early. This is usually a sign like, hey, they're about to herniate and have a really bad problem, like very, very unstable. So this is like your emergency. This is like your woo, woo, there's a problem here thing. It's Cushing's triad. And this is, it's like a trifecta. There's three symptoms that are in Cushing's triad. Increased systolic blood pressure. So there's what's called a wide pulse pressure. Now, look there, it doesn't say increased blood pressure. It says increased systolic blood pressure. So this patient has a high top number. So I mean, like this patient has a blood pressure of 210 over 75. So the top number's high, but the bottom number's still in that normal range. And I'm not going to get into the logistics of why that happens. It doesn't matter for you on this side. I know that y'all are nerds like I am and want to know, but y'all just get yourself more confused. So just understand that top number gets really high. And it's called a wide pulse pressure because that top number and that bottom number, there's a lot of space in between them. The 200 over 70, there's a lot of space between that when normally a blood pressure would be 120 over 80. There's a big difference between 120 over 80, and then 200 over 70 something, there's a lot more space there. So we look for a top number in the blood pressure being really high. Then also bradycardia, your body's trying to oppose all of the pressure that it's feeling. What do you call it, from that increased blood pressure? And then also there's all this pressure on your brain stem, so it's not getting those same signals to beat the way that it's supposed to. So you can have bradycardia, and then irregular respirations. And a lot of times, like, we call it like chain stokes. It's kind of where they, and I mean, they can have different breathing patterns, but one of the most common ones you'll see is chain stokes. And that's where like they kind of like, and then they just stop breathing. There's like a pause, and then so it's like literally like they're gasping for breath, and then there's like 20 seconds of not breathing. So this increased top number of the blood pressure is increased, heart rate is low, and then their respirations are irregular. And this is pretty much telling you they're impending death. There's so much pressure on their brain stem, those basic functions are going away. They can have eye changes. And usually for eye changes, we're going to see dilated pupils as a negative sign for these patients, and then decreased motor function and posturing. And so with posturing, the two types of posturing that there's decorticate, which I always remember, it's like you're holding over your core. Like in this picture, they say like you're rolling your hand like C's, and you're protecting your core still. So this no type of posturing is a positive sign, but it's better than doing nothing. But it's a reflex that your body does when you're not having a lot of brain function, or there's a really bad injury to your brain. And so the decorticate is a very slow. So like, let's say that I pinched my finger and I had decorticate posturing. What would happen is I would bring my arms in and kind of protect my core like this. If I had decerebrate posturing, what happens if like I pinched my finger, I would be extending out. So this is called extension posturing. So there's flexion or decorticate in towards my core, and then decerebrate, which is extension, kind of make an ease out with your hands. And again, you don't have to know that in depth about the difference between these, just what it looks like. And that decorticate is better than decerebrate, I'll put it that way. And so definitely once you're getting to decerebrate posturing, you're like right on the brink of brain death, and that's usually a very negative sign. Not that, again, the decorticate's much better, but it's definitely. I always try to remember that, like, hey, they're still protecting themselves, putting their hands over their core. So how do we measure ICP? So there's a couple different devices that we can use. We can use what are called ventriculostomies or bolts. And they can, at like places like JPS where I work, we insert them at the bedside. Sometimes they get them in surgery. Most places they probably put them in surgery. And these have two functions. They allow us to monitor and record what the ICP levels are, because there's no way to calculate ICP without actually having a device in the brain. Because in order to see that resistance or that pressure in the brain, we have to have some device in there to tell us what that is. And then some of them actually also have the ability to drain excess fluid. So if the problem is I have too much pressure, too much fluid in my brain, I can actually help regulate that by draining some of that fluid. And so my role as the nurse, if I have a patient with one of these devices, is going to be leveling it. So you remember leveling like with central lines for CVP, or leveling for arterial lines of that phlebostatic access. We do the same, except we have a different place that we level it at. I'm going to show in the next slide. We also are going to monitor the drainage if it is a drain, and then monitoring that pressure, and then kind of tailoring our care to keep that ICP within whatever the doctor's orders the range. Remember, we're usually trying to keep that 5 to 15. So this is an example of, we call it the device that's going to be attached to the ventriculostomy. And you can see like this one has a drainage that it's coming, but you can see she's using this string to measure. And so, with the when we learned about arterial lines, we zeroed them to the heart. But remember, for this one, this is something that's in the brain. So we're actually going to level it to the tragus of the ear. So we're going to come over here to the ear and going to be leveling it to that ear, so that we can make sure that it's at the right level, that we're getting the right pressures. And so you'll be doing that every shift, or with any, of course, changes. If you ever, how to bring them down to CAT scan and come back, usually we re-level it anytime we move it out of its normal position. So, what other treatments do we have for increased ICP? Of course, our goal is going to be to decrease that pressure. And so, sometimes we're going to, the doctor, not us as the nurse, but the doctor's going to go in and do procedures like a craniotomy or craniectomy. And this is literally like sometimes they'll cut out like a square of your skull and just leave it off because we need more pressure. And remember, our skull only is finite; it only has so much, way that so much space to expand. So sometimes they'll cut out a part to allow for some of that, that brain to expand. They can place the drain catheters or bolt and allow for drainage, like we talked about. One of your most common medications give is what's called Manitol. And this is a diuretic, but it's not like other diuretics. This is an osmotic diuretic, and it works specifically, helps to get fluid off of the brain. So this is used, very carefully in the ICU, and I have a different slide about it where we'll talk about it. We also want to give them medications for agitation. And we'll talk about this in a little bit, but it's a very fine balance in between giving them enough sedation to keep them from, being very agitated and restless, which can increase their ICP. But it's also not, giving them so much medication that their vital signs are tanking, and then that's going to affect their ICP and their CPP as well. And we'll talk about that in a minute. At some point, if the patient, because of their brain injury and confusion and other stuff, they're very restless and agitated. There's times that we have to give muscle relaxers. We have to intubate and medically paralyze patients. So at points, and then we want to control fever. Controlling temperature is so important because when you get a fever and you have a brain injury, it just gets your metabolism going. It gets everything running, and it's really going to increase that pressure. We also want to optimize your cerebral perfusion pressure. So we're going to maintain your hemodynamics. And we're going to do that. Usually a lot of these patients end up with hyponatremia, and so we would give the 3% saline to help treat that, and then also vasopressors. So these patients, remember we talked about that equation: CPP equals MAP minus ICP. Well, like I said, sometimes hey, their ICPs may be a little high, or maybe their ICP is normal and their blood pressure is normal, but their CPP is still not good. And so sometimes I have to drive a little bit of a higher blood pressure, that MAP greater than 70. So there's times that I have patients where they have a normal blood pressure, like maybe 100 over 75, and their MAP is 68. Great. That's usually pretty good, but it's not enough to get that CPP I need. So sometimes these patients are on vasopressors just to get that MAP up, because if my MAP is high, remember, my CPP goes up too. So I'm getting better perfusion. And that's really my goal at the end of the day, is that I'm going to be playing with my blood pressure and then also doing stuff to decrease my ICP in order to get that good cerebral perfusion pressure. And then also seizure prophylaxis and seizure medications to prevent complications. So we talked about mannitol. It's an osmotic diuretic, and it decreases that fluid volume in the brain. I need to monitor my fluid and electrolyte levels closely, because these can be altered, because this is a diuretic. So I need to be watching really closely and making sure that I'm replacing electrolytes and fluid as needed. Excuse me. And then, as you can see in this picture, mannitols actually can crystallize. So it happens sometimes, especially if there's, any sort of contamination or opening of the mannitol, it can crystallize. So after I use mannitol, if I left that tubing sitting out, a lot of times you'll actually look at the bottom of the tubing, crystals form at the end of it when it dries and stuff like that. So you have to be very careful. Obviously, I don't want crystals going into a patient, so that we use a special filter when giving this medication. And I need to always be checking my my vial and my tubing to make sure there's no crystals in or around the tubing. And then also I'm going to do serum osmolality. If you remember with all your fun endocrine stuff, that the osmolality is about how diluted, or how how many particles are in the blood. And so pretty much with mannitol, it's a diuretic, so it's going to diurese you. So if that number's really high, we're not going to give mannitol, because then that can put the patient at risk, because that's a really severe dehydration. So we'll hold that medication. So usually, in my orders, it will say, hey, if serum osmolality is greater than this, then we don't want to give that medication. So what is my role as the nurse? So I said, again, I can give vasopressors and stuff to get their MAP up, but what can I do to get that ICP down? Because that's going to be my role as the nurse, is getting that ICP down. So keeping their head of bed at least 30 degrees at all times, and keeping a neutral head alignment, which means I don't want my neck, we naturally kind of turn our head to the side when we sleep and stuff like that. If I have my head turned to the side, I need my whole It needs to have like my whole body moving, not just my neck turned to the side. So what happens is it actually, these beautiful blood carotids that I have bring in blood flow to my head. They get clamped off and can kind of they get less perfusion. We don't want to do anything that's going to decrease the perfusion. Now I know you're going to think, hey, that can't be that big of a deal, but I can just tell you, as someone who has worked with a patient who has a monitor in their brain, the difference sometimes, like a patient sitting there and their head's turned like this, and then I put their head like this, you'd be amazed at how quickly that ICP can go down if that's an issue that they're having. So keeping their neutral head alignment, I want their head bed elevated at 30 degrees, usually no more than 45 degrees. If I'm sitting up too upright, it flexes my hips and it actually increases my intra-abdominal pressure, which can increase my intracranial pressure. So usually like I'm about 30 to 45 degrees. We talked about seizure precautions, preventing injury. And then we also were talking a little bit about this analgesia sedation, like the balance. So like I mentioned, one of the big things with increased ICP is one of the things that can get up is agitation. So family in the room, in their face, bothering them, the patient coughing, waking up, like disturbed, confused, all that stuff, all that can increase your ICP. And I don't want that. So sometimes I'm going to have to give medications to kind of keep the patient calm, decrease their anxiety, kind of keep them stable while their brain is healing and that swelling's going down. But what are the side effects of all these medications? Pain medicines, anti-anxiety, sedatives, hypnotics, all this stuff. They decrease your blood pressure. Remember, what are my two parts of cerebral perfusion pressure? I have my decreased ICP, but I want to increase my MAP. And if all these medications decrease my MAP, even if so pretty much it's like working against me. I'm like, hey, I need more pressure in my brain. It's like CPP. I need my CPP to be higher, so I need to decrease my ICP. So I give them sedation to decrease their ICP, but then it also decreases their MAP. So at the end of the day, I'm still making things worse. Now I don't know if that makes sense, but effectively, sometimes it helps one part of my equation, but it hurts another. So as a whole, it's a balance, between giving enough to keep them calm if they need it. Not all patients with increased ICP need it, but if they need sedation, things like that, giving enough to keep them calm, but also not giving them so much that their blood pressure goes down. And then their blood pressure goes down, which means their MAP goes down, which means they're not getting enough pressure up here. Like I mentioned, decreased stimulation. This is the one patient I do not want to cluster care. If I cluster care, then pretty much I am putting this increased pressure all the time in their brain. I'm trying to be like, oh hey, I'm gonna go in real quick. I'm gonna do their bath, go to CT scan, talk to their family. Like that's just too much for them. This patient, I'm gonna break stuff down because I need to go in. Their pressure's gonna go up a little bit while I'm doing something. Then I'm gonna go leave, let them rest. I'm gonna go in again a little bit later. Pressure's gonna go up just a little bit instead of going in and the pressure goes up a lot and then it takes forever to come back down. I really don't want to have that. I really want to just do in little increments because they're really minimal stimulation. And I want to minimize suctioning. Anytime I suction, what am I taking out? Oxygen. And taking out that oxygen can definitely lead to a lot of issues for this patient and can decrease their oxygenation, which can drive for higher intracranial pressures. We talked about preventing or controlling fevers. And with these patients, an important thing to know is it's not like you or I when we have a fever and it's like, oh, I'll take some Tylenol and then I'll be okay. This is talking about a neurological fever, which means my brain mechanism that controls temperature isn't working. So, what happens with this is that with these patients is that giving them all the medications in the world won't do anything. They will not help because it's a temperature regulation issue. So what I have to do is regulate their environment most of the time. So I've got to and it's not saying that we don't try medicines because sometimes medicines do work, but a lot of times I end up having to use ice packs or I have to change the room temperature, put a fan on them, do whatever I have to kind of get their external environment cool because sometimes those medications aren't going to work. Strict intake and output for these patients, making sure what's going in and coming out, those electrolyte monitoring, supporting their nutrition, because most of these patients are not going to be able to eat by mouth, frequent neurological checks, usually every hour, and then monitoring their airway and breathing. Remember in the beginning, I said there's all these factors at play that affect your intracranial pressure, and it's all about oxygenation. Oxygenation causes vasoconstriction, which actually helps for better perfusion in the brain. But of course, on the opposite end, CO2 If it's high, it causes vasodilation. And that might seem like a good thing, like, oh, vasodilation, like everything's open, there's not a lot of resistance. But it actually, it goes the opposite spectrum where it's just pooling, like there's blood pooling in the brain, but it's not getting where it needs to go. So there's not as much of that push. Like anytime there's vasodilation and pooling, there's less flow everywhere. And so, we really want to be careful with that high CO2. And if you think about these patients, a lot of them are drowsy, sleepy, and maybe they're on medications that are making them drowsy and sleepy. So they're not going to have a very high respiratory rate a lot of the times. So I have to be really careful with monitoring that respiratory rate, monitoring those ABGs, and making sure that their CO2 is not too high. So, like if this patient's on a ventilator, sometimes I'll even if their CO2 is really high, we're going to change the ventilator settings in order to try to make sure we're getting effective ICP. So, yeah, so there's definitely a variety of things that we can do. So hopefully this kind of got you an introduction to ICP. I know it seems like a lot. It really is your building stones to a lot of the other stuff we're going to talk about in neuro, but hopefully this kind of got you started in feeling more comfortable with all of this information so that you can go be the fabulous nurses and we call them give this stuff right back out to your patients. So I'll see you later.